Great. Caitlin?
Hi, everyone. Caitlin Safford. I'm with the Mayor Group Washington, and I'm the MCO rep on the CRIS committee.
Michelle?
Hi, everyone. Michelle McDaniel, CEO of Crisis Connections. Tomorrow, 6 months in role. And again, thanks, Jen. And we are a Lifeline contact center.
Great. Dylan?
Dylan Nishimoto with Asian Counseling Referral Service. Actually, I'm an alum of the University of Washington School of Social Work as well. Hello.
I am too. I don't know if any of us ever crossed paths before, but and Kimberly.
Hi, everybody. Kim Hendrickson, City of Poulsbo, manager of our Poulsbo Fire Cares Co-Responder Program and chair of the State Co-Responder Outreach Association. Jen, I don't know you, but I've seen you present at the Senate Behavioral Health Subcommittee and have really appreciated your work over the years. So nice to finally meet you.
Great. Thanks for indulging me in that. So it's nice to just open it up a little bit that way. So just as a reminder, we're really going to be digging into the themes, and I don't know how clear it was. Jen, you asked a good question. At this point, I mean, I think normally in these processes, you do the report and then you do a presentation on it. But because of the timeline, what happened here is we wanted to make sure that at least our themes, before we were getting really in depth into the writing, which will be happening after this meeting, that we had collected in our data collection, that we had gotten the general sense of the, what we were hearing and sharing that with all of you to make sure that we were heading in the right direction. So that's kind of why this order is a little bit awry or weird to some folks. So I hear what you're saying. And it was the first time that HCA was seeing the themes. We're still working with them on gathering more data, and it'll be evolving over the next year. But really, I think from my perspective on this project, really what this assessment is helping us do is lay out the work that needs to be done next year. And so that's where these themes are going to springboard into. And so we'll be diving into that. But I think what we just really want to get a sense from all of you today is to just understand from your perspective, are the themes capturing the current state of what is going on, and if there's anything that we've missed. And so that's what we're trying to gather in our breakouts today. So if it would be helpful for me to go back up and put the slide deck back up and have the list, I can do that. I see nodding from Caitlin. Do you want me to do that real quick? And then I can pull it down so we can see everybody's faces too. So just because I can't remember everything. I know if it's, let me go up here. And I'm happy to go look at each of those as well. So, wow, I realized the slide deck was so long. Kimberly, go ahead. Please pipe in.
Thank you. So I'll just start with a very general comment, and then I know with this group, we'll dig down in some more useful detail. I guess my overall comment here is I'm a little bit frustrated because there seems to be two different types of crisis service delivery in Washington State. Please excuse that. There's the BHO MCO funded world, which this document has done a really nice job capturing. But there's an entirely separate world, which is made up of first responders and emergency rooms and co-responders. So I'm almost calling it like a shadow crisis response service. And it was interesting that we started our call today with a couple of people talking about the difference between the way services look on paper or the way people want to bring services and what actually happens on the ground. So speaking from the world of first responders and co-responders, I'm just disappointed that there's nothing in this document that talks about crisis response from police, from fire, from behavioral health professionals that work with police and fire, emergency rooms that don't offer psychiatric services, but yet are the primary source of care for many people experiencing crisis. So just as a way to start the conversation, is there some way perhaps as we move forward with this document that we could acknowledge this shadow system, because this is the system that most people touch when they are in crisis on their way to connecting with some of these BHASO MCO services. Thank you.
Great feedback. Representative Warwell.
Thank you. No, and I really appreciate this conversation. And I think one of the things that, it kind of struck me is it felt, and I think I'm hearing it for Kimberly, it was a very narrow view and of the system. And in fact, I didn't kind of capture our suicide hotlines, basically our lines are going to be 988. And so, like, how do we pull back a little bit so we're not trying to kind of cram 988 into what's an existing system, but actually kind of think big. Like, I just hope like the paper we're presenting is like, here's a big picture of how we can do crisis services. And here's kind of this complex system, kind of hovering below it. So I don't know. I'm still processing it. And I know it's a lot of information. You got to ground us somewhere, but it just felt like a very narrow grounding of the system.
Michelle.
Yeah, I'm processing as well. I will say that I just think it really articulated for us how convoluted the system is. And if I'm putting myself in the shoes of someone who is trying to seek services or a loved one, I get what is being said around there's this system that is kind of the official system, and then the shadow system. And that's why, ultimately we do need to blow this up and say, what is the way that we can do this so that we are doing this from the perspective of people who are accessing or need to access these services. So for me, we live this every day because we're also at Crisis Connections, our staff and volunteers are trying to also help navigate through this. And there is the official system that is also extremely fragmented and it's overly engineered and complex. And if we try to come at this of let's fix this, it's over here, we're never going to get there. We're just never going to get there. And this is why we need this concentrated time and attention and funding and creativity. At the same time, that's going to take a while. What do we do in the meantime to try to chip away? And that is why we also have kind of, in my mind, two parallel tracks right now. This larger systems level conversation, this is hard stuff. Everybody has some type of stake in the game. And so we do need to level up to have big conversations and for people to open their minds for big changes. At the same time, 988 is going to go live in July. And I'm starting to pull the alarm to say, you know what? Crisis Connections, I assume VOA and Frontier, I have more unanswered questions right now than answers. So I am talking with Betsy and Jim and the folks at DOH and whoever else will listen to say, I actually have to operationalize this. And we cannot, as a system, have 988 fail on July 16th. If we do, we're not going to be able to get ourselves out from that shadow. And we will have failed people, because at the end of the day, we all want to do right and we want to fix the system. But we only have a few months and conversations with Vibrant and the folks that are all very well-meaning. Those of us who have the contact centers right now that are expected to provide 988 to do that conversion from 10-digit to 3-digit, I'm really nervous about making sure that this is done well, because at the end of the day, we really get one shot. So I'm just putting a pitch in to say, yeah, we have many years of work to do to fix this system. But I also just want to put out there, we have some parallel track of, we need to have an operational conversation like now and start getting some specific answers. So those of us who are picking up that 988 in just a few short months, that this system doesn't fail.
Mm-hmm. I think the stories that we heard both today and also at the community forums that were held really just underscored that we've done enough re-traumatizing people and we don't want to create another thing that does that again. So very good point. So thank you. Jen.
Well, to be honest, I actually am trying to recover from that presentation. That presentation was in a sense traumatizing to me because it was, I just felt so incomplete and not capturing the reality of the situation that I think Michelle really outlined. I mean, I think what really stood out to me is there's seemingly no accountability whatsoever for what we have going on here in Washington State. The fact that we have to do a survey of the BHASOs to actually find out what seems to be some pretty cursory information about how well our system is performing. And I also find this question, honestly, I'm just being honest, like really confusing. We're asking to look at themes, but then there was some like findings that were kind of presented under the themes that were so what are we commenting on? Like the general findings or the themes that, I mean, yes, this is a way to organize a report. This is a rough outline, but I also find it confusing. Like, what are we even doing here with this breakout session? Like, are we trying to, because the reality is like, yeah, these are probably close to the right themes, although I would agree with what Kimberly said, like we're missing some key pieces around the providers. And I also think like thematically wise, like, I think we really need some case studies here, like, and beyond just like hearing like a general lived experience story. Like we have so many situations where like we know the system has failed and we can learn a ton from that. And I don't see any case analysis in here at all. And so anyway, I just feel a little bit frustrated by the whole thing because we've known this is going down since last April. And here we are like 9 months later, taking really small step forward.
I hear you. I think, the point of this breakout group and today's presentation really is to, I think, identify what's missing. And from the project perspective, I will say, I 100% agree with the issue about not having as much information as we would like on the accountability piece. It's a challenge, and I'm glad that you pointed that out in the big group because it needed to be said. Because if we don't have the data, it's really hard to actually say anything. I will say that this list too, the report will have a lot more narrative in terms of what we heard in the forums. And so, I unfortunately, the roll up of the forums that we hosted were not incorporated into this piece right here. So all of these will have that kind of underneath it. So I just want to make sure that you know that, but I think today is really about what are we missing? So Caitlin.
Yeah, I think, I'm sorry, I'm like losing my voice today. I think it's the fourth meeting I really actively participated on today. But I had similar reactions. I mean, even when we were talking about this during legislative session, sort of in my brain, I was always thinking about this, and like the systems really operate very differently. There's the suicide intervention and response system, funded very differently. Delivery of care is very different. And then there's the behavioral health crisis system. And I think that this report, again, has just shown the distinctions between that, because this is really centered on the BH crisis system. And as an MCO, like even our payment structure is totally different for somebody entering through, a potentially preventable suicide attempt or something like that, because we see them in the emergency department. It's a different model. It's a different model of care. And rarely do they cross over into a crisis evaluation or an ITA investigation in the emergency room. And so I need to see more of the data for the other side of the system of the suicide intervention and response, because it's without that, there doesn't seem to be a clear path forward about how these systems do come closer together, which then also makes me very nervous, to Michelle's point about the 988 line going live, and for entities like Crisis Connections who have to operate in both spaces and do so really effectively with high accountability measures. I mean, like the call response rate that any sort of call center has to have on the BH crisis system is very high and hard. It has been very hard to maintain in the time of COVID as well. And the only other thing I'd say is, because to me, there's like a delineation between the systems, workforce in the suicide intervention and response system, totally different solutions than potentially the workforce solutions in the crisis response system, because they're different sectors that operate, to Kim's point too, about first responders being there. And while first responders, of course, are a part of the BH crisis system, a lot of that workforce issue is really on lack of BH clinicians being available to either do the investigation or even follow up, like in trying to get next day services. Like we don't even have the workforce for next day services right now because everybody's so slammed and the BHAs are closing down clinics. And so just totally different solutions. I think it would be really helpful to understand the differences there, because we're going to have to attack it from like a policy and strategic framework differently, I think, in order to bring the systems closer together. Sorry, it was a little rambly, but those are my observations.
I want to make sure that I'm capturing this correctly, because when we report out to the larger group, I'm hearing what I think I'm hearing, and I just want to make sure that I'm capturing this right, is while we're narrowly focused, which is, what our charge is, these other systems are actually very much related to what we're doing. And we need to be kind of helping to paint that narrative. I think the shadow thing about the first responders is a really important one. And what you're saying, Caitlin, about the BH, another tangible example of like the BH workforce, because we don't have it, it impacts what happens over here in crisis, but the solutions to that are somewhat different. So we just need to be able to look holistically, but also, I don't want to use the word target, but just develop solutions that are going to address what's in front of us here, but recognize that there are other influencers. So, Jen.
Oh, this is just a small point, but it would really help me if our system could move away from talking about investigating people with mental illness. Like I can't stand
I totally
it.
agree with that.
And if we can't get that on
agree.
record, like in this process, like we're done for.
And that'll be a great thing if it comes up in the actual narrative report, when you can like see it, the words, and just like point that out. I mean, I can bring that up today, but I think that that's something that we just need to continually flag, to just push that out of the words that are being used. So, and possibly a policy solution. Dylan, we haven't heard from you yet. Please go ahead.
Thank you, everyone. I mean, I completely agree. Wow, I completely agree with all that's being shared here. If we're coming back to what we're discussing on the key themes, I think one of the things we talk about the fragmentation of the service. What I feel like was being missed is the transitions of care, especially around the follow-up after a crisis. And from my end as a behavioral health provider, it's just like, all right, they're in the ED, and then CORS or IS or someone will be sending out like, all right, now we scheduled a next day appointment, and they say 10 a.m. next day appointment, and there's nothing else that is there. And I think that is a huge miss when it comes to, they're like crisis, and then there's outpatient mental health, and there's very, very little interaction. We were at one point incentivized in creating our safety plans and uploading them to CMT. But it was nothing happened. And so we did it, and then we got our incentive, and then no. And when I saw the after hours care note, I saw like did not consult safety plan. And so we're jumping through these hoops that don't are really just making the job harder without having any outcome tied to it. And so, and the fragmentation, not just of the communication, but also fragmentation and transitions of care, I think is a huge miss that for the key themes.
Mm-hmm. And I will say, I participated in the forums, and I heard that so in every single one of them, that people were, we never know what happens to someone, nobody ever followed up. It was like the example that Kathy gave her family. That's happening all the time to people. So, okay, Kimberly.
Thank you, Liz. And I'm very sympathetic to your job of having to take a lot of comments and synthesize them quickly when we report back. I wonder if just looking at, I printed out the report on the assessment on page 6, there's a visualization of how crisis services work and how they've changed over time. Just for the point of synthesizing this feedback and inviting the report writers to broaden out their approach here. If you go to page 6,
I'm not sure. Is it theme 6 or page 6?
No, page 6. So very close to the beginning of the document when just very introductory comments were made. Yeah, you're almost there. You're on 2, 1, 3, 4. Oh, one more maybe. Oh, so your deck is different because it's the whole presentation.
Yeah, the email deck is
Oh,
different
The
from
email
the one.
different is
Yeah,
it because it got changed. Okay, so
Okay, never mind.
wait, why don't you show me a picture of it and I'll find
Okay.
it while you talk.
So is
Okay,
it
I know
titled
what that looks
Delivery
like.
of Crisis
I'll
Services?
find it. Yep, I've seen it. Okay.
Right, because I feel like if we can't even map out what the
Yes.
crisis system looks like in one visual, we'll never explain it adequately in the report. So just as a starting point, I wonder if we could focus our attention, not necessarily in this breakout room, but in our responses back to the full group, and for the sake of a fuller report, elements just in this conversation that we could add to the delivery of crisis systems are, for example, 911, police and fire. I really appreciated the comments that Caitlin was making about emergency rooms not billing the same way that BHASOs bill, having emergency rooms represented on this list. Dylan's point about some sort of follow-up crisis care, which I'd like to see incorporated in our crisis response as well, some sort of step down, that could be part of this chart. So,
Okay.
I understand we have a very tight timetable and these are very complex things to discuss, but at least if we get the chart right, we'll have something to start with. And then a question for Jen. I've seen you testify and I know you've done a lot of work on our crisis systems in Washington State. Do you have anything that you've already done in terms of case studies or analysis that you could help provide to add to this without taking too much more time? I just feel like you've done much work here, Jen. I was trying to explain to Betsy in a previous conversation about testimony that you were a part of where somebody was brought in to talk about the crisis system in Washington State. It was an outstanding presentation. Can we take information from that presentation and incorporate it into this document? Thank you.
Representative Orwell. Oh, did you move yourself out of the
Thank you.
queue? Okay.
No, this is a great discussion. Since we're on this chart,
Mhm.
my concern on this chart is it really, again, does not show the 3 call centers, and the 988 is funded by the fee. It's a universal, right? We're not looking to make 988 a payment model. The crisis services, the crisis stabilization, but so I just worry that there's not a column for 988 and crisis hotline there.
Mhm.
And of course that's, and the payment method is the telecom fee. But I just really appreciate, I want to say I really appreciate Dylan's comments. Had a bullet of follow-up and linkage to community-based services, having intensive outpatient services. There's that gap between what's provided and what people need to stay out of the hospital. And the thing I haven't seen mentioned, which I think was a critical component of Cahoots, is transportation services. And I think that's where some of these EMS models are really helpful, right? Maybe they have more of ability to transport, but also that there's a Cahoots van, right? And that's kind of part of their model, is to get people places. And so I want us to think bigger than what's currently in our system.
Right. Jen.
So I wanted to just bring up the point that, like, we actually have, it's related to what Caitlin was saying. We actually have a duplicative system right now in some ways, and we're not acknowledging that in this report because the complexity around the fact that we have these 988 call centers, much of which are one and the same with the county crisis lines call centers. The fact that the fact that we can't even explain our system, like we can't even explain our own system, is problematic. Like that we need to be designing a system for the consumer, the person with lived experience, the person in crisis. And it's, what we have right now is, I just had my twin brother move next door to me. Person with serious mental illness, trying to get him on public benefits, in healthcare, in mental health care. It is ridiculous, the fragmentation, the complexity, and the fact that the duplication isn't being represented here. And the fact that, you know, crisis connections, I say them as a great example. On one hand, with one hand, they're answering the 988 call. The other hand, they're answering the county crisis line call. They have different rules, but I mean, why aren't we talking about integration? Like, why are we not talking about integration? So like this report, I guess, is supposed to highlight the deficiencies. But and so, I mean, I also thought this was also supposed to be a report that was supposed to be highlighting the solutions. And Kimberly, to your point, I mean, there are ideas about how to integrate this, but we have to get real about being able to have those conversations publicly. And it's gonna, we have to have conversations like, where's the accountability? And if we're gonna change it and make it better.
Yeah, I definitely hear what you're saying, and the duplication, the shadow system, we need to convey that better. I really like your suggestion, Kimberly, about pointing this out to the group and say, we need to further refine this because there's pieces that are not reflected here. Absolutely. And to your comment, Jen, about we thought we were coming up with solutions. So the work of this group is the solutions over the next 2 years. This assessment is really just supposed to like lay it all out there. Like, so that's why we want to make sure if there are things that we are not identifying gaps and problems and things like that here, we want to try to get all that on paper so that we can say, we're going to be working on this over the next 2 years. This subgroup's going to do it. This subgroup's going to do it. We're going to come back together. So we are going to be doing solutions, but that solutioning will be happening after we do this. So just to kind of be super clear about that. So, and I hear you on the confusion. It is, I have dealt with a child with a lot of problems, and it has been really hard for me too. And I have an MSW too. I understand. It sucks. So, Caitlin.
I think one thing that would help too, just even on this particular slide, is like if a call comes into 988 and somebody needs like a next day appointment, but they're not a Medicaid client, like, and I'm not representing the commercial plans. You'd probably get mad at me for saying this, but you know, from the commercial perspective, that's not reflected here at all. And they would be the ones responsible for that visit. And that's if it's included in the benefit package. And so, you know, that also has to be a really big part of this discussion. And mandates around mental health services is always hard because it's like, how do you define that? Like Medicaid has clear definitions and we have clear diagnoses that are included in like state benefit package that be approved by CMS. It gets a lot more sticky on the commercial side. So I get that. But it's also like mostly a different provider set. Like it's a lot of private pay providers who don't, or providers who do not serve Medicaid clients, and they operate in a different field. And I mean, that's just such a different system to enter into. And there's different coordination that the commercial plans have versus MCOs. Like they don't do as high a level of case management as MCOs would, and they don't do as high a level of like follow-up from hospitalization. They're not always even aware of somebody's being discharged from an inpatient psych facility. Like, so all of that I think needs to be included in this discussion. I'm not even sure. I just don't know the answer to this. I don't even know if inpatient psych stays are covered by commercial insurance as a standard benefit package. I'm doubting it. And then that's that requirement is a determination for the most part of employers here that would be included in their benefit package, because the majority of lives here in Washington are covered by a large employer group. Yeah. And the state is one of them. The state is like one of the large employer groups, just as an FYI. Anyway, so those are just like a couple of other helpful additions, and it makes it like, I see Jen just like rubbing her face, and it makes it so much more complex. But if we don't have that, then we're just never we're only gonna be solving for the 2.1 million people that are on Medicaid and like the 700,000 people that are served on the non-Medicaid side through the ASOs, which are mostly Medicare, by the way, which in the VA, which also complicates things. Yeah.
So you're saying, Caitlin, just that in terms of the delivery system and all the components that we're talking about, the continuum that need to be delivered that we identified already as a missing piece, like the follow-up care, prevention, the first responders, like that needs to be reflected here. But also we're talking about up and down the payment, because we've got a whole other system around commercial insurance, Medicare, they have all these other different rules, and that's not reflected here. And that makes it really hard for the delivery system to actually do its job when you've got multiple people telling you different things. So
yeah, and if you don't mind, Rep Orwell, just one more thing too. And I don't know if it would fit here necessarily because we're really just talking about crisis services, and I'd love to hear your thoughts on this too, Dylan, because like I'm not sure if BHAs really even have the capacity for it, but I am also worried about the survivability of the behavioral health agency system if we're like entirely reliant on Medicaid, and how do we help them diversify their payer mix and drive commercial clients to those facilities, and drive commercial payers to contracting with BHAs. And if that like sounds too much from your opinion, Dylan, I totally get it, but I think that's just part of the conversation, because from an infrastructure level, I really fear we are losing them.
Representative Orwell.
Yeah, no, that's such an important point, and that's so important with 988 because that becomes a universal number, and a lot of people who are going to call have never been part of a behavioral health system, right? And even as we looked at other states that have one number, they don't have one 3-digit number, right? And so I know that's why in the bill we said in 2023 that the private plans had to do next day appointments. How those are provided and what those look like is yet to be defined. But I do agree that somehow we got to make sure whatever report is being submitted reflects a bigger system, right? Beyond behavioral health. I think that's an excellent point.
Oh, thank you. Sorry. Okay. Dylan, go ahead.
Obviously, like we're all professionals in this field of like mental health, and like we're all trying to work at this. The part that in all of this is that if this is confusing for us and what's being presented, and in the end of the day, the people that are using it, I mean, hopefully we're not finding ourselves in a situation. But as was shared earlier, any one of us are one step away from something that might happen, and we could find ourselves using a service like this. Right now, I was like, depending on funding, take these steps to access our after hours care or crisis connections or whatever it may be. I'm really hoping that this will just come down to some very, very clear and straightforward process, not processes, but a very straightforward method for people to be able to access care, and not have to be routed through 3 or 4 different places and having to tell their story to multiple different people, and then maybe a next day appointment's there or maybe it's not. And I think we're having the staffing and workforce capacity to actually, if the system becomes like the next 911, being able to have someone to actually respond to a need that's in front of them.
Thank you. Kimberly.
I'm just going to say something that you all already know, but I just feel compelled to say it, so bear with me. When the systems don't work and when people can't connect to the care they need, they call 911 and get a police or a fire response. So our default system in Washington State and elsewhere is to send a first responder and have them do the best they can to not only respond to crisis, but in the world that I live in, to do that follow-up the next day, to see if somebody was able to make an appointment. For the fire team I work for, to actually give a ride to the appointment. So we're living in a world now that when things become too complex or break down or are not accessible, there's an improper reliance in my mind on first responders. So, I mean, I've talked to Representative Orwell about this, and I appreciate her attention to this issue. The question then becomes, should we do more to equip first responders for this position that we're putting them into, or do we put all our eggs in another basket and create an alternative system? When I look at this report, clearly there's no focus, no even mention of what I'm calling the shadow system or first responders, which suggests to me that the emphasis of this project will be to just kind of close our eyes and ears and pretend that reality doesn't exist, with the hope that we can create something better. My plea to this little group and to the whole group is to realize, even as we create alternative systems, and we will, I know there'll be new and better systems created, much of the work will continue to fall on first responders when these systems do not operate as they should. So as we're working out the new alternatives, I just want to make a plea for, remember, when the shit hits the fan and nothing else works, it's police and fire. So please, could we be thinking about how to better equip police and fire? Because they're answering these calls anyway, to be more adept and more effective, and obviously more humane when they're taking these calls. Thank you.
Absolutely. Jen. Oh, you're muted.
I wanted to add just what Kimberly said. It was brought up earlier, but the reality is right now, our emergency departments are being so heavily utilized. We actually have a place where we have a lot of people who are in crisis right now who could be served even better than they currently are. And so like the fact that we need those numbers in here in this report. The other thing that's not in this report is like what's happening in terms of peer services at every point of the crisis care continuum. Like how are they being utilized at the call centers? How are they being utilized with mobile crisis teams? How are they being utilized in crisis stabilization? How many are there? Like how much do we want to, I mean, the point is it's really hard. Like how do you get from like the problem to the solution? But like we need to be able to capture peers because they're going to be key to this. And I really do feel like the emergency departments also really deserve a separate call out because they are serving the vast majority of people who are in crisis at this point, and they've been drowning for years. And the fact that we don't even mention it here, it's not even like maybe it's part of a bullet somewhere, I think is really problematic. And there's a lot of really rich interventions. I'm not suggesting that EDs is where we should be continuing to send people. That's the function of the fact that we don't have alternatives, but we absolutely need to think that at some point, at some level, they're going to continue to see people, because even if they're going to find people who don't even show up there, who are suicidal, who that's not their chief complaint. And so we have to wrap them into this and support them better as part of this as well. And it starts with showing the data that just shows the appalling number of people who are going there.
Yes, absolutely. It's a both and. I think we have to equip the folks that are already doing this work. We hope that it becomes less, but they're still going to be doing it. And so they need to be prepared to do it. So, Michelle.
So this is such a great conversation just to sit in and just kind of listen. Another thing that I see is missing is actually a discussion around prevention. So, the statistic that I see repeated over and over is that 80% of crisis line calls are resolved at the crisis line level. Now, I haven't been able to determine where that statistics come from, but I'm using it too because everybody else is. Regardless, how is it that we are thinking around prevention as well and have some discussion around that? And the systems that we have already to be able to determine where are there opportunities to think about this as a prevention model. It looks like we have 1 minute, so I'll just wrap up real quick to also say when we think about, again, from the perspective of providers like Crisis Connections, I can't tell you how much administrative time we spend audit after audit after audit because the different entities are asking us the same thing. We have all contracts are underfunding. Some we have to fight them individually. I cannot increase wages because of the way that contracting is done. So just another component around how this is not working, and it's actually wasting a lot of money.
Just scribbling. Oh, we're going back to the big room. Any final comments before we go back to the big room? And I'll be asked to do the report out and I'll do my best, but you all will also be able to just chime in if something is missing. So I really appreciate